Let's go ahead and get rolling. Appreciate everybody joining us today, and welcome to the webinar, Improving Blood Pressure Control with the AMA MAP Hypertension Program and I2I Tracks. This is the second of 3 total sessions, and today we're going to take a deeper dive into some of the details of the program and associated tools with Tracks. My name is Zach Clint. I'm the Vice President of Client Success at I2I Population Health, and I'd like to thank everybody for joining us today. So introduce our speakers. Linda Murakami, Senior Program Manager of Quality Improvement at the American Medical Association, and Josh Glick, Senior Director of Quality Management at I2I Population Health. A couple of learning objectives that we're hoping to aim at today. Participants should be able to list ways the AMA MAP hypertension process metrics for measuring blood pressure accurately and partnering with patients work in conjunction with actions and interventions to improve blood pressure control, as well as apply Tracks functionality to guide improvement to the measure and partner process metrics within AMA MAP hypertension. So with that, let me turn this over to Linda to take it from there.
Thank you, Zach. So in case you missed the overview webinar last week, I just want to let you know what MAP represents. So M stands for measure accurately, A for act rapidly, and P is for partner with patients. And these are really the pillars for our program. So for measure accurately, we're looking to obtain high quality blood pressure measurements that providers can trust and use to diagnose and manage hypertension. And for act rapidly, we're looking to initiate and intensify evidence-based treatment. And partner with patients, we want to get our patients actively involved in the management of their hypertension. And our clinical team of improvement specialists work with sites on improving blood pressure control using this framework. And I'm going to talk about the measure accurately and the partner with patient portions today, but there's a get started link or QR code at the end of the webinar where you can request information on having some customized training. Next slide. And we're going to talk about measuring accurately. So the problem is that blood pressure measurement is inaccurate, and there are many places where errors in blood pressure measurement can occur. Next slide. And this is a list of 27 things that can potentially cause blood pressure measurement errors, with some of them happening on a regular basis during the rooming process. So what we want to point out is that any of these things can occur and affect the accuracy of a blood pressure measurement. So the number one error that's listed on here is using the wrong cuff size. And using a cuff size that's too large can give us a falsely low blood pressure result, and using a cuff size that's too small will give us falsely high readings. Next slide. So since incorrect cuff size is the number one error, let's talk about how we're going to prevent that. So you want to ensure that proper cuff size, so to do that, you can measure the arm circumference. You can see the pictures at the bottom of the slide there. You measure from the top of the shoulder and you go down the back side of the arm to the bottom of the elbow. And then you find that center point between there, and that's where you should measure around the arm and do that arm circumference. Or you can use the index range. And some cuffs, when they're really old and used a lot, they might be worn out. So that's when you have to do the measurement. But the index range marker, there's the index and the range markers. When you wrap the cuff around, you can see the long line. That's the index, and that should land between the range markers. And if they don't, then you have to get either a larger or a smaller cuff size. Next slide. So now let's talk about our steps for improving. So accurate representative blood pressure measurements are essential for diagnosing and managing hypertension. And for that, we use automated validated devices that are calibrated regularly, properly prepare and position our patients, and then we want to implement a standardized measurement protocol, and we want to make sure we include repeat measurements. Next slide. So validation, that's the action of checking or proving the validity or clinical accuracy of a device. And that's done by an independent panel of hypertension experts. So they validate the model of a manufacturer's device. There's a US listing of validated devices at validatebp.org. And there's filters and things on the website that make it easy, especially if you're looking for like a specific model or something specific. Calibration, that's making sure the device is functioning properly. So calibration is performed at the clinical site on every device that you have. So there's a difference in how often calibration takes place. You can see on that little chart based on the type of device you're using. So automated devices, that's the least frequent. You only have to calibrate them every 1 to 2 years. And the portable manual devices that you carry around, you have to have those calibrated every 2 to 4 weeks because they're so fragile. You know, dropping them on the floor or even just tossing them in the drawer, that can really change and alter the accuracy of a reading. And, you know, you think about who's got manual devices, are you really, you know, calibrating them every 2 to 4 weeks? So next slide, please. So hypertension guidelines stresses the use of the automated devices. And what it does is removes those elements of human error that can occur when you're taking a manual blood pressure, like inflating the cuff high enough or deflating the cuff slowly enough, and making sure that you can hear the Karakov sounds. But the readings with these occurs with a push of a button on automated office blood pressure device known as AOBP that can be programmed to take multiple readings automatically, and it can be done without a care team member in the room. So you hit the button and you can walk out, and this really helps with any white coat effect. Next slide. So now to prepare our patient for in-office blood pressure, patients should be instructed to take their blood pressure medications as scheduled because, you know, how many patients intentionally skip morning meds before appointments, you know, just to show you how high their blood pressure really is. We want them to avoid caffeine and smoking and exercise, also large meals for 30 minutes prior to the visit. And then they should empty their bladder if needed. And you can like ask them if you're walking them to the exam room, you know, if they need to use the bathroom. And also you want to do so in have them take the readings in a quiet environment. So also, lastly, you want to allow a 3 to 5 minute rest period prior to that measurement. So the easiest way to do that is to build it in and take the blood pressure as the last thing you do. You do it last after all the questions and after all the other vital signs. Next slide, please. So I've already talked about how you select the cuff. So here we want to ensure proper positioning. Patients should be quietly seated with their back supported, their feet flat on a surface. So if they're short, you need to have a step stool for them to keep them flat. You want to put the cuff over a bare upper arm, and the arm should be supported on a table or something with the middle of the cuff at heart level. Also, there should be no talking or texting during the measurement. And this is our in-office infographic, which, you know, people hang up. It acts as a visual cue for the clinical team and for the patients because they'll, you know, help correct things if your staff don't. And you can see on here, the wrong cuff size can increase blood pressure by 2 to 10 millimeters of mercury. So you also want to make sure you have all the cuff sizes in each exam room. And then the cuff over clothing can add 5 to 50 millimeters of mercury. So yeah, it's 50 millimeters of mercury. So always make sure you have that cuff on bare skin. And then making sure those rooms, the exam rooms, are set up to support proper positioning is very important. You know, you want to make sure there's a place for the patient to rest their arm and, you know, that the chairs have back support. Next slide. So one thing to keep in mind when you're creating a measurement workflow is to really specify who's taking the measurements. So a patient's blood pressure naturally rises when a member of a healthcare team walks into the room, and we refer to that as the alerting response. But you can see on this graph that a patient's blood pressure rises about 12 millimeters of mercury less when the nurse walks in the room. That's a blue arrow versus when the doctor walks in the room, which is the red one. And you could see there's a 5-minute and a 10-minute increment. So after the 10 minutes, after the nurse being in the room, the patient's blood pressure is actually almost back to baseline, back to normal. But with the provider in the room, it's still 12 millimeters of mercury higher. So this is why we want nurses and medical assistants to take the patient's blood pressures instead of physicians, because there's a less of an alerting response in the room. And honestly, you know, we know that the nurses and the medical assistants, they're trained more frequently and retrained more frequently on how to take a blood pressure measurement so we can provide more accurate measurements. Next slide. So we suggest standardizing your measurement protocol so that everyone does it the same way. So you take an initial blood pressure, and if that's high, and it should be like greater than or equal to 140/90, you should repeat the blood pressure measurements. So you take 2 to 3 more readings. You're going to do them 1 minute apart, and then average the additional readings, and then you're going to document the confirmatory reading in the EHR. And we say to do this because, like, the bigger studies over the last 30 years, they've all used the average of multiple readings to treat. And it's usually 2 to 3 readings. Science tells us that 1 blood pressure reading isn't reliable, and it's a guideline recommendation as well. So you want to be sure there's a process in place for notifying the provider of the higher measurements. And this can be done with a verbal alert, an EHR alert, or a visual cue. And we have sites we've worked with that are using heart-shaped magnets, and you put them on the door frame. So when the provider or a physician walks in the room, they know there's a high blood pressure that they need to address with this patient. Next slide, please. And now we'll talk about the metrics to measure accurately. So we just talked about that measurement protocol, right? And taking the additional readings. So this is the metric that's going to track that. It reviews how often patients with uncontrolled blood pressure have an additional measurement taken to confirm the high result. So we've listed the simple definition here. It's the percent of patients percent of visits for patients age 18 to 85 with essential hypertension with at least 1 uncontrolled blood pressure reading. So that's greater than or equal to 140/90, and had a confirmatory blood pressure measured during that same visit. The repeated blood pressure is done to confirm that initial reading was truly high. And remember, 1 reading isn't reliable. And our suggested starting goal for this is greater than or equal to 50%. So you need to make sure that that repeat is documented in that EHR. And people, find it a challenge to do this extra reading. So this is really a great way to track that. Next slide, please. So the tips, here I kind of mentioned already, again, standardize a process so that everybody who needs that repeat blood pressure measurement gets it. And then make sure, like I said, you document that average in a vital sign field. You have to have that more than 1 blood pressure to get the credit for it. If you can, have a field delineated for that average, or make a note somewhere so people know this is an average of however many readings, if it's your process for 2 or 3. And then again, always train your team on any new processes. Next slide. So we're going to talk about partnering with our patients. We talk about partnering because we want our patients to be engaged in their care. We want them to participate in the planning and the treatment that they receive. So there's patient responsibility in managing blood pressure, and we want to improve areas where there may be gaps. So here we want to improve their adherence to their treatment, make sure they can schedule follow-up appointments, and make it to those follow-up appointments. Make sure they show up. Next slide. So here's some steps for improving. We suggest for partnering with our patients, and we'll touch on these, following up frequently until blood pressure is controlled, supporting patients in medication adherence, and we want to talk about using collaborative communication, and encouraging the use of self-measured blood pressure, or what we call SMBP. Next slide. So frequent follow-up should occur every 2 to 4 weeks until blood pressure is controlled, okay, until we achieve that blood pressure control. And this is to evaluate if treatment's effective or if it needs to be modified. So we want to get the patient scheduled, and so we should consider, setting up a process with the front desk for scheduling patients before they leave their visit. You can use nurses or medical assistants for the follow-up visits. Self-measured blood pressure is also a way it can be utilized. We usually do it 2 weeks after a treatment change, but it can also, confirm, that in-office blood pressure was still high or not. So we're going to talk more about SMBP coming up. Next slide, please. So to capture patients who don't actually schedule their appointments before they leave, or they may have been missed, you want to use patient outreach. So finding a way to develop lists, looking at patients who had high blood pressure on their last visit, but they haven't been seen in, 3, 6 months, 8 months, whatever, beyond the 4 weeks. So you want to consider like pulling these lists and then reaching out to them, making calls or using patient portals, You can send letters, or if there's a text messaging service that you're using. We have places that are using their medical assistants or nurses. Some people have access to population health teams or patient reps in central scheduling that can also help make these outreach calls and then get the patient scheduled. And where you can, always customize or personalize messages if you're speaking to the patient so that they know that you're calling from the doctor's office. Sometimes we have central scheduling, somewhere calling, they don't know that's the doctor's office really speaking to them. So make that clear. Next slide, please. So the medication treatment plan, that also, requires patient adherence. And there's a lot of things that can impact patient adherence to their meds. For example, we want to make sure they get access to the pharmacy or the costs associated with the meds. They may have actual or feared side effects of the medications, and then the complexity of the medication regimens that are prescribed. Polypharmacy, how many medications are these patients on? So looking at access, like, does their pharmacy deliver, or can they find one closer to home? Or use mail order? Can they be connected with a discount pharmacy if cost is an issue, or 403B type programs? Some of those online programs that have discounted drugs, really work for certain patients based on their meds. And then hypertension doesn't cause any symptoms, and it's the silent killer, right? So we know that they might not feel any symptoms and may not feel that they need any treatment. They don't feel sick. So they need to understand why the medications are important and why they need to take them daily. Next slide, please. So here's a tool that we use to help us communicate better with patients. So it's, our collaborative communication strategies. And it's really simple. It's about being non-judgmental and working on how we talk and ask questions to our patients. Back at nursing school, for me, it was called therapeutic communication. And it's all kind of similar. It's talking about using open-ended questions. And when we're training patients, we want to use teach back. So we make sure they really did understand what we told them. So, and this is really just a couple of examples that we have listed. Next slide. Next slide. So self-measured blood pressure, our hypertension guidelines suggest that the use of SMBP for blood pressure control can be used, and it's an excellent way to partner with our patients. So implementing SMBP with co-interventions like having patient support, education, and ongoing management, making sure we're communicating with our patients during this SMBP process, has been shown to improve systolic blood pressure by 6.1 millimeters of mercury. And that's enough to, get some patients, back into control. So we have a 7-step guide that'll help you, kind of takes you through identifying which patients will be qualifying for SMBP. Talks about using validated devices, like we mentioned. We want to do that for self-measured blood pressure as well as proper cuff sizes. We want to train our patients on how to perform SMBP and how to get the results back to the care team. We do the same for patients. Like, we just go through how you should position patients in the office. We do the same at home. We want proper positioning where they're seated with, back support, feet flat, and so on. And we've also got guidance on how you should average the results, because all the results should be averaged when we usually take it for about a week. And also guidance on, how to determine treatment. And then making sure we have documentation and communication with the patient. So there's links again at the end of this presentation, and we're going to make sure you guys get the slides and the links to all of that. Next slide, please. Okay, so we're going to talk about partnering with patients and the metrics. So the first one is follow-up visits within 4 weeks. So guidelines have been recommending frequent follow-up for decades. And so this metric tracks how often a patient returned for a follow-up visit within 4 weeks after a visit with a blood pressure of greater than or equal to 140/90. We're looking at the percentage of patients aged 18 to 85. So our suggested starting goal is 50% or higher. We know that this doesn't always happen in the real world, so it's just a really great way to track. And remember, there should be follow-up visits every 4 weeks until you get blood pressure controlled. Next slide. So for getting patients in for follow-up, there's lots of ways to improve, like I mentioned, making the appointments before they leave, tracking the patients who didn't make their appointments, making sure we get in touch with them. We don't want to lose these patients to follow-up. And, identifying patients who don't show up for their appointments, using those lists. And then using nurse and medical assistant blood pressure visits. So you can actually schedule follow-up, not with a provider or physician, but with a nurse or a medical assistant, and they just get a documented blood pressure visit into the EHR. Now, if their blood pressure is high, we need to address it, of course, but this can also work. And the self-measured blood pressure readings can also count as follow-up blood pressure visits. You have to, again, get the readings from the patient and document it in a field so it's identified as blood pressure readings, and then always delineate that they're SMBP average readings. Next slide, please. So here's the systolic blood pressure reduction after a medication intensification. So it's kind of hard to track how often patients are taking their meds. We can't see what they're doing. And so this measure tracks the average change of the systolic blood pressure after medication intensification. So after a medication has been added to the patient's regimen. And this helps show patient adherence of their medications and effectiveness of the medications prescribed. So if we see improvement in their blood pressure, we're going to assume that they're taking their medications as prescribed. But if we don't see any improvement, we have to use collaborative communication and investigate if they're taking their medications every day. If they say they're taking their meds every day, then we have to look at the treatment that's being given. We might have to, again, escalate the medications and change, things around a little bit with the meds in the treatment plan. But if they say they're not, taking their meds regularly, then we need to address. And, because of this way this measure is calculated, we don't have any suggested goals other than seeing a reduction of some type. Next slide, please. So here's how we would improve med adherence, right? We talk about patient adherence. The literature tells us that patients are taking their meds 50% of the time. But when they take their meds, the literature also tells us they're taking it wrong 50% of the time. And medications need to be taken 80% of the time or higher for them to be effective. So you want to take time to explain to patients about their medications and why they need to take them and why take them every day. And again, we need to be judgmental and try to understand their concerns or why they're not taking it daily. Again, looking at those reasons that they might not be able to get their medications or afford their medications, and then collaborating in a way that the patient feels comfortable, and then, work together on solutions like I had discussed earlier. And now I will pass it to Josh. Thanks.
Thanks, Linda. That was incredibly informative to learn all about the various techniques and different ways that we can partner with our patients. So thanks so much for that introduction. And we're going to get into some of the tracks functionality now, that in ways that you can also support your patients in measuring and partnering as well. And so firstly, let's recap, go back where we talked a little bit last week, which is about accessing the report. Sorry if that looks a little bit grainy on your screens there, but you can access the AMA MAP Hypertension reports by navigating to the reports header at the top of your screen, going to AMA, and then you have the option to choose either the report or the dashboard, and you can run those from there. If you log into your Tracks database today and you notice that you do not have a dashboard, it's because you need to upgrade to version 7.6.30. And that actually just came out on Tuesday. All right, so if you haven't upgraded yet, go ahead and upgrade as soon as possible, and you will have access to the dashboards as well. So once you get there, this is actually another enhancement that we've added with the new version. You'll notice on the right-hand side that you can also add races and ethnicities when you're running a report or a dashboard. So a lot of the other configurations were available previously, right? You could choose locations, providers, financial classes, migrant status, homeless status, and tracking types. But if you like to further stratify your report, you can also run this by race and ethnicity. And while the main advantage is that we created this was for the AMA report, you'll actually have access to those options in any report that you run in Tracks henceforth. When you're running your report for the AMA MAP Hypertension Program, you're going to want to run it for either 1 month or a 1 year period, depending on how far back you're wanting to look as you continue to track along the way. And the dashboard, when you're going to run the dashboard, you're only going to have to set the end date. And the reason for that is because the dashboards are always going to load a 12-month period back in time. Okay. That way you have enough trended data to look at over time. And so it's always just going to work back that 12 months. So go ahead and set whatever end date or anchor date that you want. And if you notice in the screenshot here, the start date is actually grayed out. This is an example of me trying to run the dashboard and not the report. Obviously, in the report, you would set your start date as well as your end date. Okay, so once we get into running the report, this is an example where we are breaking it down by location. So we've got I2I Clinic downtown, we've got I2I Clinic Northeast, and then we also have a cumulative total for these various locations. This is important with the MAP hypertension program because they're going to work with you to identify which of your locations you want to implement this program. And so it might be just one of your sites, it might be several of your sites. And this will give you the ability to analyze which sites are utilizing the new workflows and compare and contrast how well those sites are improving in comparison to some of your other organizational sites. Another feature that you're going to want to enable so that you can share this report with all of your users, whether it be your medical providers, your nurses, your C-suite staff, whoever wants access to this, there's no limitations. You can set up a report scheduler. So what I've displayed here is how to access that screen. If you go to Setup, Printing and Reporting, and then navigate to your report scheduler, this is where you can set that up. Now, if your report scheduler is grayed out, it probably means that you have not configured your email settings on your Tracks instance. So you can reach out to us, open up a support ticket, or it actually only requires some simple email server information in the Tracks setup screen. So you go to File, Admin Tools, and then set up your email server. Your own IT team should be able to help you with that, but if you need some additional assistance, we can always help to support that. Once you get that set up, click on the report scheduler. You're going to be able to choose the report that you want to run, and you can choose how frequently you want to run it. So what we're doing is when we're distributing this to the AMA from each organization, we're running it on the first day of every month, and we are looking back for a 1 month period, and then we're setting up another one of these that's looking back from a rolling year period. Okay, so we actually do 2 of these, and again, you can do as many as you'd like to share with your staff as well. You can choose to export in either Excel or PDF. I like to choose both. You know, some folks like to see the data and manipulate the data in Excel file, maybe do some pivot tables and really dig deep into the data. And other folks might just want to see the numbers, right? So you have the option, and then all you have to do at the bottom is fill out your email addresses of where you would like to send these. As I mentioned earlier, the visualizations are going to help your organization to see areas of improvement. So as it relates to partnering with patients and measuring accurately, we've highlighted some of the trending that you'll want to be focusing on, as Linda had mentioned earlier, right? Confirmatory repeated blood pressures, SBP reduction after medication intensification, and making sure that those patients are getting in for those follow-up visits. So you can begin to look at trends, how many patients are coming in for those follow-ups. If you're starting to see a trend downward, then maybe you need to utilize some other tools to get folks in. Maybe you have to call them twice to get them in. Maybe you have to call them 3 times to get them in. And so you can start to deploy some of the other areas of tracks, such as follow-ups, such as recalls, in order to get patients in for those follow-up visits. Trending of data can really help you to identify those. Measuring accurately is important in terms of getting good information, also important in terms of looking at our data. So whenever you're running a report, you can audit the patients that are coming into your report by right-clicking on the numerator or denominator and showing patients that meet or do not meet the criteria. And so this helps to give you that audit list, right? So if you want to audit your patients that are not in the numerator, you'll right-click and say show patients that do not meet the criteria. Then you can start to look at those blood pressures, look at when the last blood pressure was taken. You can drill down to the patient level details, and you can really start to look at, okay, how are we getting these blood pressures? Are the blood pressures accurate? How many blood pressures are we taking? You can start to look into that data and see where you can make those improvements. One area as we begin to set up tools for measuring and tools for partnering with patients, one great area is to start to set up protocols. You may have heard of alerts before. Alerts populate to your morning huddle, and there's 2 different ways that we can create alerts. We can create alerts with a schedule, and then we can also create alerts with a protocol. Schedules actually can't be created for vitals. So that's why we're going straight to the protocols. So schedules kind of have a little template that you can fill out on a data element, right? So let's say the example of a colonoscopy, you can fill out all the different criteria. It must be done every 10 years if they haven't had a FIT or an FOBT in the last year, and you can start to set up that form. Vitals don't actually have that form. So what we can do is we can set up a protocol and we can start to display all the patients that have a blood pressure that is out of range. If you've never worked with protocols before, only administrators actually have access to the protocol section in Tracks. And so when the administrator clicks on the dropdown in your search for patients area, you can choose that protocol section and then go ahead and put your search in there that you would like to display when patients are coming up as due. Another protocol, so I put a simple one in here, hypertensive patients whose most recent blood pressure is greater than or equal to 140/90. But another example that you could put in there would be patients who have been identified in the AMA MAP BP program and have not had a follow-up in the last 4 weeks. And so you can use that with tracking types. You can create a tracking type to say, these are the patients in the program. You can then start to look at who's had their initial visit and who has not had a follow-up visit. In addition, as you're creating these searches, start to think about some of the actions that you can take with these patients, right? So whenever you run a search, you get your actions menu, you can send letters, you can send text messages, you can create follow-ups. These are all incredibly helpful ways that you can begin to partner with patients. You can outreach to patients, as Linda had, and really start to engage and get those patients back in the door. So here's a quick example of the morning huddle. Okay. And by the way, there is no PHI on the screen. This is from a demo database. So there's no risk of PHI. Just wanted to make sure that I mentioned that. But this is an example of a hypertensive patient, which you see in that green lettered H. This will always show up if the patient has a diagnosis of hypertension. And we've just created a quick protocol, as you saw on the previous screen, that says hypertensive patients with blood pressure greater than or equal to 140/90. And I messed up the equal sign, but you get the idea. And so this is an example. Patients are coming in the door, and the care team can meet every morning and they can say, hey, these are the patients coming in for the day, and these are patients that we have to make sure that we're doing the blood pressures correct. We should do it on every patient, but let's make sure that we really focus in on how we're doing the blood pressures. Let's make sure that we take multiple blood pressures. Let's follow all the guidelines that Linda just covered, and let's make sure that we give them some informational things that we can partner with them and get them back in and really make sure that they're monitoring this on a regular basis. Okay, so that's the huddle report. So that's again for your care team. And then another area that I think is going to be really useful in this program is the patient visit summary. And not everybody uses the patient visit summaries, but they can be an incredibly powerful tool because if I go back real quick and I look at the huddle, well, this example only has one patient, but normally the huddle has multiple patients that are all coming in throughout the day. So you can't give that to a patient because it has all that PHI on it, right? But if I go back to the patient visit summary, this is individualized. And I've actually created one that is specific to hypertension. So I've created a little graph where I can show this individual patient's blood pressures, systolic and diastolic over time. So I can print out a copy for me, the provider, I can print out a copy for my patient, and I can give them a copy of this and say, look at how well you've done after we've made these changes. Look at how well you've done and how the improvements that you have made by us partnering together. So incredibly powerful tool. I do have some organizations that I worked with that are using it in this way. It can also be utilized as an EMR downtime tool because look at all the information that's here. You've got problems, you've got medications, you've got what they're due for, you've got a history of their blood pressures. So incredibly powerful tool that I don't think gets used nearly enough. So if you've ever wondered, how do I get this? How do I use it? It's really simple. Where's it going? Here we go. You can set it up under setup, printing and reporting, and then your patient visits summaries section. There's a little bit more setup that has to go into this. You actually have to set up a profile. So you notice just above printing and reporting, there's a section called patient profiles, and you'll have to set up a hypertensive profile to feed into the patient visit summary. If you've never done that before, you can either reach out to your CSC or PHC. We'll be more than happy to help you out with that. But it's also in chapter 25 of the help menu that's in I2I Tracks. And it'll teach you how to create a patient visit summary, how to create your patient profiles, and do all of those things from scratch. So we've got lots and lots of tools available at your disposal that you can, again, make sure that you're measuring accurately, review those levels and review the measurements that your team has been taking, and then also tools that you can use to partner with your patients.
All right.
So
So
go ahead, Linda.
yeah, I think it comes back to me. So we'll do hypertension support opportunities. So we'll go to the next slide. So we want to make sure you have a centralized hub for all your learning and resource needs. So in I2I University, there's a lot of AMA MAP hypertension resources, including this our metric user guide and a validation guide we're going to talk about in a second. Plus, you'll find all the webinar recordings from the learning series. So these two, the first two, and then our third one coming next week. So if you're not able to attend, you can re-listen, or you can listen to the ones you missed or share them with your team. All the content's right here. Next slide. So the metric user guide that I mentioned, this is a resource that combines the information from our MAP QI program along with the I2I Tracks functionality and to help support your use of the metrics. There's detailed metric specifications. The one I gave you earlier were just simple definitions. And this is going to help you support your interpretation and the validation of the metrics. There's links also in here to the AMA MAP hypertension tools and resources. I'm going to point out a few in a sec. That you can use to leverage and drive improvement for your organization. And next slide. Oh, sorry. So here's the links to that page. It's on page 26 when you open the user guide. That can to help you with the improvement. So you can see what we have for measure accurately and partner with patients. Next week we'll be talking about acting rapidly. Next slide, please. And that's you, Josh.
Yeah, we also have the validation guide. So this is a quick handbook that goes through some of the steps that I just mentioned for running your report, making sure you're setting the right time frames, right-clicking and being able to analyze your patient lists, making sure that you're breaking down by locations, clicking all the right buttons to get the data that you need to help support in the program. So that's also available on I2I University, and it should help you along the way.
Lastly, we have last week's webinar. That was the official kickoff of this independent learning series for the AMA MAP Hypertension Program in collaboration with I2I. So that was reflected as a high-level overview. And then we had today's session. Like I said, they're both on I2I University. The third session's next week on August 8th, and that's focusing on ACT rapidly. So we're going to talk about clinical inertia or treatment inertia. So that one really, we encourage physicians and providers and pharmacists to attend on your team because it talks about, their workflows. And ACT rapidly is, just very heavily dependent on treatment decisions. So we're going to drop that registration link in the chat for you for signing up. And next slide, I think we're ready for questions if there are any.
And if you have any questions, feel free to drop them in the Q&A. We do have a couple to start with. Linda, this first one is directed at you. What are some practical solutions to ensuring accurate blood pressure measurement if my organization can't afford new AOBPs?
So the best way then, if you're using manual devices, is to make sure all of your devices are calibrated properly. And when we talk about calibration, it's more than just making sure there's no holes or anything in the tubing or the cuff. It's about they actually connect it to what they call a pressurometer, where there's like T-tubes and other tubes, and determine that it is inflating and deflating according to the proper pressure. So it's a bigger check than I think most people understand. And then the other things are to follow all the steps we talk about for measuring accurately, which is, positioning your patients properly. And then lastly, for that, I'm going to say do very good competency assessments on your team for manual blood pressure measurements, making sure they're inflating it properly, deflating it properly, which is at, 2 millimeters per second. And palpating the radial pulse when you're inflating, so you know how high to pump up the cuff. Things like that are very important. I'd say those very basic skills are important to review.
Great, thank you, Linda. And Josh, there's another question here that seems a little more directed at you. What I2I reports would you recommend if I have the clinical team for the clinical team use versus what I might send to executive leaders?
Yeah, that's a great question. I think, honestly, I would send both the AMA report and the dashboard to both teams. I don't think it's going to hurt to share more information. So your executive team is probably going to want to see the trending, but they also might want to see the data, because the trending is going to show you your percentages, but the data behind that is going to show you the actual volume, the actual numbers of patients that are falling into those denominators and numerators. And they also might want to see the breakout by location, right? So you might have one location that has a very high population that's out of compliance, and another location that's doing great. So that's an opportunity as a leader of the organization to say, how can we take what we're doing well here and share that knowledge with other locations, right? Very important education sessions, having those internal learning sessions within your organization to make sure that everybody's following the same workflow, the same protocol, and that you can really learn from the providers that are excelling at these sort of programs. And again, for the clinical staff or the clinical support staff, that's just as important, I feel, to be able to share that information. So I would share both.
Great, thank you. I am not seeing any other questions in the chat or in the Q&A in this moment or in the chat. Linda or Josh, anything additional from your vantage point?
Think I'm good. Thanks for joining, though.
Yeah, nothing else here. Thanks everyone for joining today's session.
Yeah, before everybody hangs up, Linda and Josh, thank you both for sharing your expertise. I'm going to call out again for all the participants in the chat. This is a 3-part series, 2 of 3, and the link to register for next week's webinar is in the chat. So you perfectly welcome to leverage that and get yourself registered for next week if you'd like. I think feeling confident that the partnership with the AMA and bringing the content and building a lot of both the reporting as well as the dashboarding into eye-to-eye tracks brings a lot of value to a lot of organizations who could leverage these tools to help improve performance around the blood pressure. So appreciating the AMA team and their collaboration. So with that, as long as there aren't any other questions, thank you, as Linda said, for joining today. We look forward to hopefully joining next week. Everyone have a fantastic day. Thank you.
Thank you.